So how many of you were actually here to see the video? Initial reactions to what you saw. What are people thinking? You had a hand up. Let's start with you.
Oh, sorry.
I guess as a developer, it's a little intimidating seeing the effort that it takes just to start to get into healthcare. It's something I'm interested in shifting towards, but it is a little daunting to see all the hoops that some of those developers had to jump through just to get funding and to get attention.
And I will say, can I jump in on that? Because that is a great thing. So you're a developer and you'd like to, but working with healthcare, how do you do that? I will tell you that I'm at a university that anybody who was like you that came in and said, I would love to work with you, we would be falling over each other. So I see people going, yes, we know. So don't be afraid, reach out. And yes.
On that topic of like, how do you break in and how do you know what rules to play by? There'll be a panel tomorrow morning on that topic with AM X-ray, the Journal of Medical Extended Reality, and INFRA that I'll be moderating and addressing those sorts of challenges of how do you prepare for that and position yourself to play by the rules and work through the process. 9:30 tomorrow morning.
Thank you very much. Here we go.
On kind of a reaction about the pitch, I loved seeing that we're able to actually talk about this because I'm in the life science and healthcare space, and I love the technology. I'm really jonesing for the immersive tech and healthcare to really come together. So now we're actually having the conversation, like let's connect, let's try to figure out what we can do because patients' lives are the priority in healthcare, and we're losing valuable time because we can't adapt or we're not willing to kind of put that first step into the pond to really try out these new tech.
Anybody else, initial reactions? Here we go, over here. So, go, Sophia. I'll keep taking your job.
I love that the issue that Red Team is picked was maternal health. As an equity advocate, I work for the largest Medi-Cal organization here in Los Angeles. It's huge and it's heartbreaking to see that how avoidable it is, but there's so many steps involved in getting that tech in place, and so that he chose that as the first issue to tackle. Like, these are solvable problems, almost one of the biggest problems in our century. I mean, even Venus Williams had her
Was that terrible?
dangerous time, the people with the most, resources. And so when you think about those who are the other side, the ones that are just trying to get by with having there's still providers that have fax machines, and so to see the divide and the gap of digital health and the equity issues, it's should raise alarms like this, and more money should be pouring in because these are the most important things, their lives. So I'm really glad that this video exists, and I'm excited to show it to our Chief Equity Officer.
Excellent. And for those of you who don't know, this is available on Prime Video. It is available on Prime Video. So if you type in the pitch into Google, it'll pop up. Or if you talk to your computer, it will pop up that way too. Any other initial reactions that we want to hear from people? Okay, Devin, what are your reactions and what are you thinking?
So when I first watched it, I didn't take any notes. I just listened. This next time that I saw this, I wrote down a couple of things that really stuck out to me that people were saying on there, and I think it impacts how we design and build XR solutions for healthcare. It is the human impact. That's an important one, design for the human impact. These learners grew up on tech. They're digital natives. That's these new doctors, these new nurses. So we're designing for something that's really exciting because it's easier for them to pick it up than it is for the people who are teaching them to pick it up, who have been doing simulation the same way for 50 years.
And I am one of those, and yes, it's harder for me to pick it up.
But you go for it, right? She's a nurse expert in teaching nurses, and she's all about this technology, and she's excited for the day that the form factor reaches the glasses, and we don't need to wear a box on our faces. And not a lot of people are doing this. One of the things that struck me was that this documentary focused on like 3 or 4 use cases. And that IXL, they showed a multidisciplinary sim center in Nebraska. I've been there. We were both there at SimGhosts. It's phenomenal. Staffed by like 15 simulationists. It's like 6 stories, $90 million. It's incredible. There's not a lot of those. But there is about 2,500 simulation centers globally and just under 1,000 in the US. And those simulation centers are connected to colleges and hospitals. So there is room, there is opportunity there, and there is solution. But the fact that they said that not a lot of people are doing this shows that the big, well-funded simulation centers are going for it, and the smaller ones that need this kind of like distributed, remote type of learning or solutions, they're not there yet. The opportunity is there. They've been doing simulation the same way for 60 years. Sim 1 is a mannequin. It's like the first mannequin ever created. It was 59 years ago, 1955 or something like that. And we're still simulating on that same type of mannequin. But it doesn't have to be that way, and it's kind of up to us to usher in the solution. And I think the biggest challenge is how do you provide the ROI for them? And what were they saying in the documentary was you have to provide the business case. And I love what you said you said human lives. It's about human lives. Yes, of course it's about human lives. That's kind of too broad and too vague. It's kind of like too soft, too mushy, kind of like that's intangible. But post-surgical readmit rates in hospitals cannot be reimbursed if that patient goes back into the hospital within 2 weeks of being discharged. So what does that look like? You go in for a knee replacement, simple, single day, outpatient, have a great day, you're getting a new knee, you get a bunch of instructions, medications, you're gonna be fine, call us if you need us. And then you go, they do another knee replacement, you go home, pain meds wear off, swelling builds, you start getting in pain. You're not a doctor, is this infected? What do I do? A couple days goes by, the pain's getting worse, you're taking your medicine. I think this is infected, so you call, and they go, we can't tell you if it's infected over the phone. If you think you need to be seen, come in and be seen. So you're like, okay, well, I can't get an appointment at my PCP for like a month, so I'll just go to the emergency department because the urgent care is not going to be able to help me. They don't know anything about my knee surgery. I'm going to go back to the hospital where I was treated. You walk into the emergency department, and the triage nurse is like, what are you doing here? And you're like, well, look at it. It's red and swollen. They're like, yeah, they cut you open 4 days ago. Of course it's red and swollen. If you need to be seen, sit down in the waiting room. We'll get you seen. You get triaged. You go back. The doctor sees you and goes, what are you doing here? Everyone's sick. And you're like, well, is it infected? They go, no, it's not infected. Here's more pain meds. Go home. And they go home with a hospital-acquired illness. And then they get admitted. And the hospital cannot reimburse for that. That's dollars. It's also lives. But we have to look for the business case. And there's a lot of business case to be had. I've got a million numbers in my head to share. But it's important to think about that because the numbers are published. Hospitals track everything. The Joint Commission audits hospitals. They walk through and say, you're not doing this right, you're not doing that right, we're going to ding you, we're going to fee you, we're going to downgrade you. So hospitals track those things. They measure those things. They have sentinel events that they have to prepare for. They have continued education that they have to keep their people certified in the hospital. They measure medication errors. They measure all these challenges, halos, high acuity, low occurrence events. So like those are problems that you can build, that we can build solutions for that have an actual business case and save lives.
What he said. After that, more reactions. Anybody actually doing this? Anybody working with partners?
So we created an application to help nurses train to change the dressing on a central venous catheter.
Awesome.
Beautiful.
With the idea that that training is really important to have sterile procedure, and getting that information with like worksheets or with videos that you have to play on a computer involves touching some kind of surface. So we put all of the information that the nurse needs in the context of the mannequin that they're using to practice changing the dressing, and we put that onto the Apple Vision Pro, and we're hoping to really get this used in hospitals and have a bunch of nurses use it for training.
Fabulous, and I think a lot of people would be willing to buy that.
Well, I got a question for you about that. Why did you choose that?
Well, if I'm being honest, it was a project that was assigned to us because an actual like hospital person
Yes.
was like, this is a problem that we have.
Huge problem.
To train nurses to change the dressing, they had actually already made a version of it for the HoloLens, and they asked us to make an updated version of it for the Apple Vision Pro, which just looks better, has like better quality of hand tracking, and just in general, the design is a little bit easier to use. So the reason we did it is mostly because somebody actually requested that we do it, and we were like, yay, a problem that's been given to me, and I don't have to come up with it.
Exactly. That is a big one. And the first people to ever win a research award at the other meeting that, again, I saw this video, were people who had devised just-in-time training for central line dressing change, because it is highly, highly dangerous, straight line into your heart with all kinds of infection issues. So wonderful opportunity for you. And now are they going to publish what the results were and that they worked with you?
That's the goal.
So we're currently in talks with a local hospital in the Boston area right now.
Excellent. Excellent. So don't let these stories, when you get this opportunity, not get published, because people need to know that it's happening.
Yeah, and we're gonna demo this tomorrow, 11 to 1.
Excellent.
Great.
Better-
Go to their
where?
demo.
Where?
Builders Nexus, right?
Yeah, the MIT Reality Hack booth downstairs tomorrow from 11 to 1.
MIT Reality Hack booth downstairs tomorrow from 11 to 1.
We also have
Right.
the Vision Pros, and we even brought a mannequin. So if you find us, we're happy to do demos.
Okay, so let's put some numbers to the why. Okay, so in 2016, got to make sure I got my numbers right. In 2016, the Association of Healthcare Journalists published in BMJ that the third leading cause of death of a human being in America is medical errors, preventable hospital-acquired illness, error, medical problems. That's like ahead of car crashes, gunshots. That's like heart disease, cancer, and then stuff that we can prevent in the hospital. Like 1 in 4 people are going to be a victim of a medical error when you go in for treatment. And guess what? We're all going to have to get health care eventually. Part of those medical errors are published by the Joint Commission. Patient identification, effective communication, safe medication use, reducing harm from medication equipment and alarms, and preventing hospital-acquired infections. Like 4 of those touch on what you're doing. But because you have to identify the right patient before you start changing their dressing or before you put anything in the line. And if the wristband was printed incorrectly on the patient, that's a problem that can happen. So what does this look like in terms of the business case? So from 2014 to 2016, an 8% drop in hospital-acquired conditions equates to 8,000 lives and $2.9 billion. So this is why they're already publishing numbers. The data is there. And when you build a solution, think about how it's more than just like one specific thing that you're solving. Because the patient interaction is an assessment, a nursing assessment. She can speak to it more than I can. When I worked in the hospital, I was an emergency paramedic. But it's an introduction. It's checking your wristband. It's finding out your history, making sure you're reading the chart correctly, identifying your primary care provider's care and associating that with what medications you're receiving today, being an incredible, intelligent nurse and stopping the doctor from giving this because you know that, because you're deep in the chart.
That's exactly right. That's another thing that is being worked on. And we see a lot of this interaction and learning how to talk, conversational things. Downstairs, Convai, C-O-N-V-A-I, was a big company and have nice avatars. Many others, I'm sure, are here, but that's the one that's sticking in my mind right now. Lots of opportunity to practice. Learning to tell somebody, no, please don't do that, or let's stop a second, especially nurses to physicians. A lot of times we know, but we will not say anything until after the fact. And you think, I just went through nursing school. We taught you a lot. How come we weren't able to get that out to you? Culture trumps everything we teach. So if the culture is that don't speak up till after the fact, that's what's going to happen. So we need to break that culture and make it normal to break that before, or to speak up before bad things happen. And that takes, for a lot of people, a lot of guts. Anybody else have anything that they're doing that they want to share? They're in the back.
So we've built out 4 different health and medical pieces. We're based in Australia, and what I'm curious about is in Australia, the way that it works is it's very public funding based hospital healthcare, which means it's very siloed. Each hospital has their own budget, and it's very difficult to be able to do a widespread distribution. I'm really interested in understanding the American model around that because it feels completely different, and how complex it will be, because these are universal skills that we've built into VR, how complicated it will be to then be able to introduce them into the American market.
The first thing that I would say is that the biggest hurdle, or I'll just say one of the largest hurdles, I don't know if I know the biggest, but you're talking about approaching an entire market that has been doing simulation the same way, and you're bringing them like goggles, and they're like, we have to do things hands-on. I'm not going to help learn CPR or learn how to do an IV with like controllers or touching the air. And while we would all love to believe that you can put on gloves and haptic vests and stuff and it will feel like you're touching skin, is the ROI actually there for that? Because in that instance, I can actually just teach you much quicker in person right now how we do it at the hospital here. And so I think that there's a hardware adoption like barrier curve that has to happen. And that piece of hardware has to be super secure, because these hospitals have extremely secure Wi-Fi, cloud compute, it's connected to PHI. Like, you will not be allowed to get on the Wi-Fi and just connect the headset. If that same Wi-Fi, there's PHI on there, there's patient information, patient health information on there.
Patient health information.
There you go.
Yeah.
I will say, I'd love to tell you that we have a system. We do not have a system here. There is no system. And that each little hospital is its own little thing, and then they're in little regional areas, and then there might be a big one, or a larger region. There might be American Hospital Association, but no, we have no system. It will be every bit as bad as in Australia, only probably worse.
I think we have actually a guest here in the audience who might be able to speak a little further. His name is Bob Fine with IVRHA, and he's
Do you know what we're
man.
talking about, Bob?
Devin, great to see you. I didn't
Good to see you, my friend.
just something I wanted to bring up, and I brought up because you guys have been starting to get more on the simulation side of training, and something I only learned recently. I got asked to participate in a AAMC working group on standardization around simulation, and even though sim is not my expertise, but on the XR side. But something I learned as they're kind of dealing with, and I don't know how this necessarily impacts maybe ongoing professional training, but at least on the school side, the nursing schools and medical schools, I did not know that the nursing and physician state boards dictate how much training can be done in VR versus traditional, and that is one of the roadblocks towards, well, or at least increasing the amount of training that can be done in immersive, at least.
It's even worse than that, actually. So the National State Council Boards of Nursing will say that 50% of a clinical interaction can be replaced with high-fidelity simulation. That's not necessarily immersive. High-fidelity simulation means a mannequin and like people running it, and it bleeds and it talks, or you have a standardized patient, someone's pretending to give birth or whatever. It's high fidelity. And you can include immersive if feels real, which it helps if it's AI. It helps if it talks to you like a human, if it feels real. But that's not necessarily the state's rule. So the National State Board of Nursing, NCBSN or whatever it is, they might say 50%, but California says 25. And then now you're stuck with 25. So there is also an advocation side of this.
Let me jump
yeah.
in here. Along with that, 50% sounds awesome because that's a lot of hours in almost any program. But there's a comma with well-trained educators.
Yes.
Which there's usually absolutely no money for. So if you want to make a good business case, you need to build in the ability to train people to use your product and be able to help them be able to train effectively using your product. If you can do that, which most companies ignore, people will beat a path to your door. Word will spread, I can guarantee it. So right now we have in our own nursing profession, we're going through the thing where nursing education is not considered an advanced skill. You can be a nurse practitioner, I can have a master's and a PhD in this or that, but education does not count in nursing, which is, again, another problem for us. Not your problem, but my problem. So again, being able to train people to use your product effectively and get it to work for them is going to be half your battle. It is NCSBN rules, and yet we will throw people in, and people volunteer. Oh, I'll do it. They know nothing about education, but we hire them to teach because they have a degree and a pulse.
And there's a
they
shortage.
And there's a shortage, and they want to help.
My name is Sonal. I head VR Academy in Dubai, where we are enabling youth to create their own applications. One of the big proposals that we have given is to Fatima College for Health Sciences in Abu Dhabi to basically create a platform for training doctors and nurses. I have my own child who's suffered chemotherapy, and I was cloning him, in Unreal Engine with this avatar, but not just physically, but also using AI, his responses, so that you can talk to him in VR. And I believe that really the technology is there really to use it for practice, not just looking at how we behave outside, but looking at anatomy and physiology as well. But how far do you believe, that's what my question is, that we are really looking at real-time, or not real, forget real-time, patient digital twins, firstly for training and then possibly for research, how far are we there and what needs to be done for a wider adoption of using digital twins, immersive?
I think you're talking about something that's super important, which is that you can't just build one patient game and expect that to apply for any patient across a state or a country, because everyone's different and diabetes looks different on you, then you, then you, then you, and so does cancer. And so really the platform play is the way to go. It's not necessarily, I don't know if I would argue that it's important that you completely create a perfect replica digital twin of each patient, but we do need to categorize this type of difficult disease and be able to apply that physiology to different body types, different ethnicities, because we all respond differently. And so that is important. In the United States, every state is different. You don't know if the hospital is using national or state protocols or the school is, and that's where the platform play is extremely important. And it's the same internationally. They treat different. The medication standards are different. The people are different. We're all different. So you really have got to give people the opportunity to treat difference in medicine. Does that mean cloning everybody? I think that's a big lift. Does it mean providing a platform that allows you to make adjustments quickly to different types of avatar types? I think that would be a much sweeter spot to be in.
Yeah. Hi. I just have a question about ROI. And I realize the importance of ROI.
Sure.
But at the end of the day, if the clinician doesn't want to use the technology does not get used. So it doesn't, making things as simple and as easy as possible for a clinician to use trump any kind of ROI number you can come up with.
That's interesting. I want to speak to two different things. One is there a difference between direct patient care and then continued education or recertification or preparation for patient care? Because you're right. When they're at the bedside, that physician just goes, this is my instrument, this is how I'm doing it, this is the way it's going to be. That physician is also still required, and so are the nurses, and there are, 25 times more nurses than there are doctors out there. But they still have to do their recertification training, and they're stuck with mannequins, right? They're stuck with task trainers. They don't necessarily like it. They have to do it to keep their license. And so that's the opportunity to insert better competency. So that way when the healthcare professional is at the bedside, there was more practice that was more effective to help guide their decision-making, their critical thinking, their clinical judgment, because they're always going to pick up the 18 gauge. That's going to be their go-to. But we need to help them more with why, when, how, double check, and those things can be done in advance to the patient care interaction. I would also argue that I think it's a really big lift to ask AI to be involved in that patient care interaction today. I think we are a ways to go from like a robot treating a patient. We're just getting started. I think Epic is just getting started with AI in the charting system to help save time. So we're early here, and there's lots of opportunity. I got to talk about 2030. Go ahead.
I'm going to say one thing, and we're coming to a close, aren't we?
Yeah,
I'm going to say
a few minutes
change
over.
will come one death or retirement at a time.
That's right.
In healthcare.
You've been a nurse for 25 years. We're just going to wait for you to turn over, or you've been a doctor for 40 years. Okay, so 2030, Got to get these numbers out. 1 million nurses are going to retire by 2030. The World Health Organization has already announced 11 million shortage of frontline healthcare workers. 4.5 million of those are nurses by 2030. We are already short of 500,000 in the United States today. 50% of nurses, when they graduate school and then they go into the workforce, within the first 2 years quit their job. 33% of them leave the profession altogether. 65,000 nursing students were waitlisted in 2023. There were no more seats. And the do not rehire rate for staffing agencies that are sending nurses to different states is 60 to 70%, which means that hospital needed more nurses, so the staffing agency sent them, and the hospital said they weren't good enough, they're not competent, send them back. So this is all gearing towards 2030. The opportunity is there, the metrics are being published, and whether you like it or not, it's going to be a lot harder for us, all of us in the hospital, if we don't start helping them get more competent faster with the tools that we understand. It's a big lift.
I agree.
Thank you so much, Devin and Susie. This was a very insightful moderation on healthcare and technology.